Hello everyone, let us discuss about UTI, urinary tract infection. It is the infections of the urinary tract. Anatomically, it is divided into upper and lower urinary tract infections. Upper means the infections of the kidney and lower means the bladder and the urethra. The common causative organisms are E. coli, Staphylococcus saprophyticus, Klebsiella, Proteus, and it is classified um, according to like clinical presentations, asymptomatic and symptomatic. Asymptomatic bacteria means the patient has no symptoms but the culture is positive. Generally we doesn't require any treatment, but if the patient is pregnant we should treat. And next is bacteria with clinical symptoms. And with respect to severity, it is divided into complicated and uncomplicated. Complicated, uncomplicated means it is only confined to the bladder in case of female, and complicated means it has systemic manifestations like in male, pregnancy, catheterized patients, uncontrolled diabetic patients, and procedures like stenting and tubing. Let's say the upper and lower urinary tract infections. Upper we have 3P: pyelonephritis, prostatitis, and perinephric abscess. In case of upper, there is fever and the flank pain. But in perinephric abscess, we have persistent fever despite use of antibiotic. There is perinephric abscess. The ultimate treatment is drainage of the abscess. In lower, we have cystitis and urethritis. Cystitis means involvement of bladder. Urethritis means involvement of urethra. In cystitis, we have symptoms like dysuria, urgency, frequency, hematuria, and suprapubic pain or tenderness. There will be no any fever. But if the patient has these symptoms with urethral discharge, then it comes under urethritis. The common causative organism for urethritis are chlamydia and gonorrhea. For diagnosis, we can do urine analysis. It is the best initial test. We should take mid-stream samples or direct from the catheterization if the patient is female, children, and bedridden patients. We see for pyuria more than 5 WBC per eye power field or 8 to 10 WBC per cubic millimeters. We can see the positive leukocyte storage. It is the enzyme produced by the WBC. Or we can do urine cultures in complicated UTI, pyelonephritis, history of recurrent UTI, or anatomical or functional abnormalities. Urine culture is not required for urethritis and cystitis. We can do imaging in case of obstructions, recurrent and early recurrence of UTI despite of the appropriate treatment for 2 weeks. CT scan with or without contrast. USC can be done in pregnant patients. Now let's see the treatment. For urethritis, we have ceftriaxone 250 mg intramuscularly and 1 gram azithromycin per oral, 1 dose stat, or we can give doxycycline 100 mg BD for 7 days plus azithro 1 gram per oral stat. And for cystitis uncomplicated, for treatment is given for 3 to 5 days. It can be given by nitrofurantoin 100 mg for 5 days, or trimethoprim plus oxymethonium per oral for 3 days, or fosfomycin 3 gram stat dose. For complicated, we should treat for 7 to 14 days. We can give orally ciprofloxacin 500 mg BD or trimethoprim plus oxymethonium 160 800 mg BD or ceftriaxone 1 gram IV for 24 hourly. Next is pyelonephritis. We have pyelonephritis can be treated in OPD and IPD. In outpatient, we can give ciprofloxacin 500 mg BD for 7 to 14 days or trimethoprim plus oxymethonium 160 800 mg BD for 7 to 14 days. If we admit the patient, we should give ceftriaxone 1 gram for 14 days OD or aminoglycosides like gentamicin 5 mg per kg per IV every 24 hourly. Other treatment includes cefepime, carbapenems, tazobactam or piperacillin, etc. Now let's see for recurrent UTI. Recurrent UTI means occurrence of UTI for more than 2 times in 6 months or more than 3 times in 1 year. We should give chemoprophylaxis for that. It is continuous or intermittent. Continuous can be given using trimethoprim 100 mg per oral OD, nitrofurantoin 50 to 100 mg per oral OD, or fosfomycin 3 gram per oral once every 10 days. Intermittent is given in case of postcoital prophylaxis recommended in women with recurrent UTI associated with sexual activity. Trimethoprim plus oxymethonium 40 to 100 per oral 1 to 2 dap once. Cephalexin 250 mg per oral once, or nitrofurantoin 50 to 100 mg once. Now let's see how can we prevent. It can be prevented by behavioral modifications like increasing the fluid, timely bladder voiding, postcoital voiding, and maintaining genital hygiene. Okay, thank you.